for before. So firstly, just to let you know that we'll be recording tonight's event for those who aren't able to make it. And I will be inviting each panel member to the microphone to talk for 5 minutes. And after they've all had their turn to speak, we'll have a Q&A session at the end. To manage questions, all attendees will be on mute. So if you have something to ask, please submit this in the Zoom chat. And for those that haven't used that before, you'll find this by hovering your cursor over the main screen. And when the menu bar pops up at the bottom, just click on the chat button. You'll see it in there. And you can sort of see that you can direct your question to certain people or to everyone. So this brings me to this evening's session. Mental illness is more common than most people think and can have a severe impact on New Zealanders' lives. I think that I really don't need to tell this audience that. The 2017-2018 New Zealand Health Survey estimated that around 650,000 New Zealanders, that's 1 in 6, have been diagnosed with depression at some stage in their lives. So to hear more perspectives about this incredibly important issue, I would like to introduce the first of our panelists who will talk to us about the challenges of delivering mental health support at scale and the role of technology to address these barriers. I'd like to welcome CEO and co-founder of Clearhead, Dr. Angela Lim.
Yeah, thank you for the introduction, David. Tēnā koutou katoa, everyone. Thank you for taking the time to join us tonight. I thought I will just briefly share with you why I started Clearhead and try and answer a few questions as well from Andrew, Bharat, Miriam, Samir, and Alison through my 5 minutes discussion. So my background is I migrated from Malaysia when I was 15. I studied at Auckland University's medical school and started my pediatrics training at Starship Hospital. Really loved clinical work, but was very frustrated by the fact that it felt like we were constantly leaving the ambulance at the bottom of the cliff. And I think a large part of why I'm driven to do what I do is around sort of tackling inequality that exists in our health system. And mental health was a really obvious one where the system was clearly not working for most people. And you just need to look at the fact that we have the highest youth suicide rate across the OECD countries to know that. In fact, we're the #1, but the second country that is with the second highest number is actually 8 times less than us. So the difference is huge per capita. So there was a real, I guess, challenge around meeting that. And when I took a break from clinical medicine in September 2018 to start Clearhead, this was before the government inquiry report came out, any sort of associated funding. And so what I kind of learned during that process and was that in the context of this group is that actually for Māori, Pacifica, and Asian, actually about 80% of these population groups don't access primary care as their first point of call for psychological support. And when you look at the fact that majority of the funding is going to GPs as the first point of call, you've kind of failed most of the people already. So that I feel it's really important to understand what is the problem that you're trying to solve and ask the right question. And so off the back of that, I really tried to say, okay, when you look at these inequities, what are the barriers in which accessing care is fundamental to that issue? And obviously stigma is one of them. And so how do you provide a digital interface in which it's would be considered judgment-free? And so that was why we decided to embark on the online support system. And so we thought about, okay, let's think about access and what are the challenges. The first is like people need access to therapy but can't find them. So we built, I guess, what we call Airbnb, but for therapists. So you can easily find therapists and then book online based on their availability. Then we looked at the chatbot as a way of not having a person judging you, even though, as doctors, we will never judge you, but people's perception is that we do. So one of the super cool things we found out is that the chatbot really is is able to kind of allow you to do that self-interpretation. It's kind of like when you think about books versus movies. Why is the books always much richer? It's because you embed within it all the experiences and networks that you have, versus sort of a movie kind of tells you what the person looks like. So that's really cool. The other thing is, like, as doctors, we often have these 15-minute slots as GPs, and most of us won't know all the resources available at the tip of our hands. So we curated hundreds of these resources, like videos, websites, meditation guides that are, you know, specific for example, for Maori and Pacifica. So it's really easy to search for what is appropriate for you and all of that. You know, when you kind of put those basics in place around addressing access, it allows you to kind of front load, basically, when we think about suicide prevention. So quickly moving forward, thinking about with the different cultures, it's how do we define mental health? And that actually stigma manifests in very different ways. So for example, an Asian person will say, my child is failing in his exams, but they won't say that my child has depression. So, so really thinking about how do you use the fact that for most of these diverse populations, we are much more of a collectivist society versus an individualistic society, and how do we rejig our health system to incorporate more of that? And I think Te Whare Tapawha is a good way of looking at those models, where it's very much incorporating a lot more of a holistic view, a lot more of a community view around support. And then, because we know that 50% of those who commit suicide are never known to the mental health services, how do we join up other sectors, such as education, employment, in a way to kind of really think about providing that support for people, and the role of technology to provide that across the sector and have it available 24/7. And yeah, and so I think I'm timed, so I might leave it there and pass it on to the next person.
Thank you, Angela. That's great. Thanks for kicking us off there. Any questions, please just put them into the chat for Angela, and we can pick those up at the Q&A session at the end of tonight. So one nice little feature of Zoom, for those who've used it, are polls. So it just allows us to ask a couple of quick questions and just get a feel across the attendees as to their particular views on certain things. So we'd love to hear from you on this one. You'll see a poll pop on your screen shortly, and just about online mental health service technology and apps. So, and I will release the results after the next speaker. Speaking of which, that next speaker is the Chief Executive of HealthTRX, and he will talk to us about whether people are accessing mental health care and support when they need it. So please welcome Anil Thapliyal. Anil's going to share his screen, so I should see that.
Kia ora, everyone. Can you hear me?
Yep, we're good, Anil.
All right, great. So as David has said, I'm going to be speaking on do people access mental health care and support when they need it. So just to put it in context, I'm using the Australian stats. In 2017, 3,128 young people took their life in Australia. And 75%, that's 2,346 of those, had not sought help from health services 1 year prior to taking their life. So the challenge is quite clear to most of the countries as to how do we make sure that we reach out to the people who are not reaching out to services. And that number in New Zealand stands at 77%. So how are we using technology? And because the nature of some of our countries, remote and rural regions, is quite profound. So looking at the use of technology and how we are interacting with it. There's a survey from UK, and it's talking about how we're using phones, and looking at number 1 is texting, number 2 is email, number 3 is Facebook, number 4 is camera, reading news, shopping online, checking the weather, WhatsApp, banking, YouTube, and number 11 is making the phone calls from phone. So I think just illustrates how the world has changed and how we are using the technology for a variety of reasons. So in terms of, I'm not too sure how many of you are familiar with, but the rapid adoption of technology, that is eMental health, within New Zealand context. So we got, Angela did an excellent presentation on Clearhead. But apart from that, there are so many other solutions in mental health, beating the blues in primary care, just a thought, and there are big white wall, there's a journal, which is National Depression Initiative 1737. We got so many initiatives, and you'd be surprised if you saw the statistics and how many thousands of people every day from within New Zealand are accessing these services. So it most of the time comes as a surprise to people. So, but understanding e-mental health or digital mental health is not just about apps and websites. It's across 4 subdomains. One of them is what we refer to as engagement, where the pre and post receiving the services we receive from mental health sector, to information provision around promotion prevention. So intervention, which is where we look at step care pathways for mild to moderate to acute end of the interventions, which is also sometimes referred to as treatment. Then we're looking at the social support element post-discharge. But when we are looking at these online solutions, one of the study which was published in JAMA in 2019 in April, 29 of the 36 apps that were looked at in this study were sharing the patient data with the third parties for commercial gain. So not all online solutions are safe. Currently, there are 327,000 apps. Only 15% of those minimum standards for them to be safe by the consumers to be used. So when we talk about these solutions, what are those solutions? So of course we talk about, have they been co-designed with and a person with the lived mental health experience, or what we sometimes refer to them as consumers or service users. Is there evidence which says it works? Who says it works? Are there evidence-informed content within there, and have there been randomized controlled trial behind some of those initiatives? Looking at, are there alignment with the policy, what government has priorities, are they working within those contexts within which the funding and planning works? Looking at also workforce development, Angela talked about the pressure of 15-minute consults. So how do the doctors know how to prescribe, what to prescribe, and that too within this 15-minute context? So e-prescribing we're talking about, and also be partnership with the industry. So total number of the challenges, 668 people took their life in 2017-18. 71% of them were male, 21% of them were Maori, and 6% of them were Asian. So in terms of just wrapping up my comments, looking at community-based solutions, not all solutions would be technology-based solutions, not all solutions would be when people are not even reaching out to services, but looking at some of the key attributes in mental health are compassion, listening, and empathy. So this is a solution, amazing community-based solution that was born out of Zimbabwe, with which they called virtual friendship bench, they call it, where every member of the community is part of the solution. So you sit there and somebody else can come along and sit with you. So the other person who is just, you're talking to, all attributes they have, the skill they bring to the table is compassion, listening, and empathy, and are able to provide you the practical help and advice. So what we're talking about, eMental health, if we re-pivot the conversation, eMental health is nothing else but a virtual friendship bench. I'll expand more later. Thank you.
Thank you, Anil. That's great. Very interesting statistics. I think we have the results of poll number 1 in now. I'll just wait for Anil to finish sharing. So you should see that there. So really interesting about the use of technology and apps. So I think that 40% there have not used before is an incredible opportunity for companies like Anil and Angela's and others. So very interesting. Thank you for participating in poll number 1. We have one more a bit later on. Look, our next speaker really needs no introduction. From forensic psychiatrist to Indigenous researcher to television presenter and author, there's not much she hasn't done. So here to talk about Māori mental health inequities and solutions, I'd like to introduce Hinemoa Elder.
Tēnā koutou katoa, ko pārengarenga te pātaka kai, ko tāwhitirahi te maunga whakamarumaru o tiwi, ko awapaka te punaroi mata, no muri whenua hau ko Hinemoa tōku ingoa. Thank you. Yes, I want to focus on some of the key issues that I see as relevant here and to interrogate those. Also want to mihi to all the speakers and everyone who's chosen to turn up this evening. Such an important issue, and I think if there's one thing that's come out of this COVID environment, it's a recognition that mental health is at the heart of what we need to embrace in the days to come, in the years to come. So as you just heard, I introduced myself using my pepeha. So the pepeha is something you might be familiar with. It's a Māori way of using statements which prioritise significant landmarks and the stories located there. So, I talked about my ocean, my mountain, my river, my area of the country, which is the very far north of Aotearoa. And so in this way, I'm clearly identifying myself according to those aspects of my identity. And identity is at the core of good mental health for Māori. And I'd argue actually for all peoples, and we're talking about diversity tonight, so we're talking about ethnic diversity, diversity of age, of sexual orientation. There are so many myriad ways that we express ourselves as human, and I think the pepeha is a really interesting ancestral technology that we can certainly use today and can be relevant today alongside the other things that people have already mentioned. So I want to lay that down as the sort of foundation piece, and we'll come back to that, because some of the other words like health, research have very difficult resonances for Indigenous peoples. So our concepts of health tend to be much more holistic and stem from reciprocal, interwoven relationships with the planet and the natural world. And that's in contrast with much of the discourse which is related to the practice of medicine. Mihi to my colleague, thank you for speaking earlier. Fascinating the work that you're doing with technology. But much of this is related to pathology and identifying pathology. And in fact, as Indigenous peoples, and there's a huge body of literature about this, we're much more interested in talking about what's working well for us as an entry point in terms of therapy, in terms of intervening, to help people identify what the potential differences might be in the way people live to promote better mental health. So for me, the key issue is leading and determining our own mental health and our own research and our own technological responses to suffering, to oppression, to not being self-determining in colonised countries like Aotearoa. So, we hear Māori mental health bandied about. It's a concept I struggle with. We as Māori have come through an era of rapid transition where there were almost no Māori coming to the attention of what were called, mental health services. And it's a similar story for Indigenous peoples around the world. And now we are the ones who dominate the landscape in terms of mental illness, mental ill health, by any measure you care to name. And we've heard about suicide. This is an emergency in Aotearoa. We have the highest rates of young male suicide in the world in our Māori community, and the rates in Australia for Aboriginal Torres Strait Islander young men are appalling also. So, you look at any parameter you might want to measure, seclusion rates, compulsory treatment orders, and because those things are easy to count, and so I want to challenge all of us to think deeply about this tonight. Just because we can count things easily doesn't make them the most important things, but they do take on their own validity and their own power, and they continue to be used, usually without reference to these other parameters that are more nuanced and more difficult to measure. And unfortunately, the other effect of focusing on what's easy to count is that it gets inside people's minds. So Indigenous people, we re-victimize ourselves because we're reminded all the time of how bad things are for us. So it's important to identify the things that are a problem, but that's a necessary but not sufficient approach to my way of thinking. So it's important for me that we actually, rather than focusing on pathology only, we need to look at the structures that maintain people's experience of ill mental health. And much of that is about racism and discrimination. I wish it wasn't the case, but there is no level playing field. And I wouldn't be surprised if everyone who's listening to this and participating in this wānanga, in this podcast, has experienced some sort of discrimination, because we all come from diverse backgrounds, and dominant cultures like to deal with us without our ideologies, without our cultures, without our language. They'd much rather deal with us as some sort of generic patient that speaks English. So maybe you can understand a bit about why I'm not so keen on this concept of Māori mental health. I just want to talk a bit about maybe some of the things that we could address. One, which might appear radical or bold. First, I think we need to deal with the mind-body split problem. So our holism, and that's true for many cultures, not only Māori, is a big part of how we think. And unfortunately, even models like the ones that have been mentioned, Whare Tapa Whā has been a very useful framework. But I think we need to be able to deconstruct the ways in which it operates. It also splits the mind and the body. It has tinana and it has hinengaro. And it has these four cornerstones, but it doesn't help us understand how those four cornerstones relate to each other. And it doesn't include things like whakapapa or whenua. So I think it's been a useful cartoon, if you like, to help disseminate very broad ways of thinking from a Māori perspective. But I don't think we should stop at Whare Tapa Whā. So I think the mind-body split is the first thing we need to deal with. You know, any of you who've ever been to a mental health service will know that it's usually located somewhere at the back of the hospital grounds, or somewhere virtually impossible to find, at some distance from the physical therapy wards like orthopedics or general surgery or general medicine. And that, I think, is a great example of how we treat people who have mental distress. We put them down the back. We really would rather not have to deal with those people. And that's still the case. You know, this is exactly the same, really, without too much change. Maybe a bit of packaging has changed, but this is how things were dealt with in the Victorian era.
Thank you,
I've probably run out of time. Maybe if I could say one more thing.
Yeah, sure.
The other thing I think we need to address is that there's an individual frame of reference. So many people from many cultures don't relate to the dominant culture, the Pākehā culture's privileging of independence, of autonomy. We think collectively and about connectivity of groups. So I think that's another one of the problems inherent to, and I think it's a problem for technology at the moment, which is very much about one-to-one relationships. So I think that's a challenge for all of us who are involved in trying to create technology that resonates with the way people actually live. And many of us in diverse cultures live in collective groups. So thank you. Look forward to your questions. Nami.
Thank you, Hinemoa. I think you'll get plenty of some really searching comments there, so thank you for that. We will have a very quick poll, number 2, which is around mental health services, which we'd be quite keen to hear your responses on those. But while that's coming through, I'd next like to introduce the National Director of Asian Family Services, who will talk about sharing some recent research, actually, on a New Zealand Asian mental health and wellbeing findings and some key mental health observations over the COVID-19 period. So I'd like to introduce Kelly Feng.
Hi, good evening, everyone, and thank you for coming for the forum. I'm going to share with you some of the service, what we see in the front line, and also some of the findings for the recent research regarding COVID-19. So So since the COVID-19, our service saw increase of demand for mental health support. For example, our Asian helpline received an increase of number of calls, a new client also from mainstream referrals to us because of language barriers and they needing more culturally appropriate services for counseling as well. So AFS, Asian Family Services, is seeing more diverse family issues and mental health related and race related bullying and discrimination in schools and workplaces. Mental health problems brought to our attention since the COVID-19 outbreak. We are receiving a high number of cases involving immigration Asian women experiencing family violence and quite vulnerable situation, and also international students experiencing psychosomatic symptoms related to worry and guilt around not to be able to go back to their country to care for their old adults and parents. So we are offering health information and counseling to those parents really struggling and extra worry about their children's safety around schools and do they send their children to school or not. We are supporting a lot of people experiencing financial hardship and due to job loss and pay cut, and some business that has been closed down as well during this time. Sadly, we've also been supporting people lost their loved ones, and 2 of the international students, Korean and Chinese, complete suicide during the lockdown as well. So, so we have done this. I'm just going to share my screen for the PowerPoint, so you can see the research recently done. Okay. Can you all see it? Yep. Okay. So I'm just going to share some of the findings recently. So since the lockdown, at least 43.9% Asian have experienced some form of mental health distress, and nervousness and anxiety is most widely experienced, about 57%. Chinese experience feeling nervousness and anxiety at the most. So about under 50 years old experiencing nervousness, anxiety more as well. We also did some findings because that's part of our core business for gambling. 66% of Asians engage with gambling activities in the last 12 months. So that's national average is about 38%. And the most common, of course, buying lotto ticket online as well. That's crossed quite a number of ethnic group as well. About 70% Asian who engage in the gambling activity in the last 12 months also engage online gambling during the COVID-19 lockdown as well. So this means 50% of Asian engage online gambling during the lockdown time. And we also had a few sad case that people lost quite a significant amount of money during the lockdown as well. So that's compared with the national average, only 30%. And in this research, we also found out that the racial discrimination since COVID-19 is relatively small for the percentage, about 16.2%. But if you calculate that to the Asian population, that's about 84,000 people experiencing racial discrimination during this time as well, especially higher for among Korean and Chinese and young Asians as well. So for those gamblers, about 61% and 72% victim of racial discrimination were more prone to experiencing serious mental health issues than those who were not. So that shows, indicates that those people are quite vulnerable and at risk as well. And just to come back to, Dr. Angela is saying about Asian help-seeking behavior. This research also tells us most Asians are talking to their problems about mental health, any other related issues to their friends first. About 44% people will choose to talk to their friends and family members is a second choice, about 42%, and then is the family doctor of only about 28%. So, but that's compared with the mainstream national data, it's about 69% mainstream people will seek professional help. I think that's some kind of a gap for there. There's a lot of Asian that are less likely to seek help from doctors and other professionals. Hence, some of the education campaigns and professional kind of mental health services are probably needed as well. I think there will be a long-term mental health impact after this pandemic. Therefore, ongoing service development is required to address some of the service gap. And of course, having a more culturally appropriate mental health addiction service reflecting more diverse population in New Zealand as well. So AFS is pleased to receive some small funding from the ministry just to kind of for the next 6 months to extend our helpline capacity to help some of the Asian at-risk population, and also translate some of the mental health information into different Asian language, and helping to disseminate some of the Ministry of Health information to our people as well. Because of the challenge, a lot of people are using different media and source because of language barrier. They might not get to the mainstream media. So they get those mixed message that might not be relevant and causing a lot of anxiety and for those people. So our service is a charitable trust that we will be sharing some of the information around this network, so you can passing on. Currently, people can access in 8 different languages, so that's kind of a free for the next 6 months. So that will be some kind of a helping for the community as well. And we also kind of did some of suicide prevention work in Chinese and Korean in the past 2 years. So some of the resources that we can share the link among our network, and to helping people reduce some of the anxiety, and video and resource as well. So thank you.
Thank you, Kelly. Some really interesting statistics, some quite shocking ones in there as well. So thank you, that's very interesting. Just a reminder, everyone, that to put any questions you might have into the chat function. I do have some that were submitted before the event, which we'll kick off the Q&A session with. But if you had any others that have popped up as you listen to the speakers, please just include them in the chat. We'll pick them up there. Results poll number 2, please, Marina. So very interesting again. So look, almost a reverse of what I believe might come through, but anyhow, some very interesting stuff there. Look, on to our final speaker. He is here to talk to us about sexual orientation and gender identity change efforts, and he is the co-founder of the Conversion Therapy Action Group and Open Government Partnership Youth Collective. So please welcome Shaneel Lal.
Kia ora koutou. I am Shaneel Lal, and thank you to everyone that's joined us tonight. I want to talk about something that isn't necessarily recognized as an issue by mainstream New Zealand, and that is sexual orientation and gender identity change efforts. It's also known as conversion therapy, and other ridiculous things such as gay cure, etc., etc. The simple idea here is that it is possible to change someone that is LGBTQIA+ to being cisgendered and heterosexual. In the past, it has existed in many, many forms. It has also existed in the form of electroconvulsive therapy. But now a lot of people have turned to things such as psychoanalysis or evasive therapy, such as snipping yourself with a rubber band if you have a thought that is not heteronormative. One of the bigger, however, breeding grounds for conversion therapy now is religious organizations where young people are told that their sexual orientation is a sin. I remember the story of a young boy named Chris who was only 16 years old when his church introduced him to conversion therapy, and he remembers, and he tells people that he remembers praying to God to either heal him or kill him. And as we find out later, it's actually quite damaging. So conversion therapy in New Zealand is currently legal. It is a pseudoscientific practice with no medical or psychological backing. It is now widely condemned by medical bodies and legal bodies. And last month, the UN called for a global ban on conversion therapy. But more importantly, in New Zealand, we've got the New Zealand Psychological Society, the New Zealand College of Clinical Psychologists, we've got the New Zealand Psychologist Board and the New Zealand Association of Counsellors who've all come together and showed their opposition to conversion therapy. They have labeled it as ineffective, unethical, and often leading to extreme harm. There is absolutely no evidence that conversion therapy works. However, there is a significant amount of information that shows that conversion therapy can be extremely harmful. But before that, what we need to establish is the well-being status of queer people in New Zealand. It's not that well. The Ministry of Education and Outline released some stats last year about young queer people, and what they found was that young queer people are 5 times more likely to commit suicide than their non-queer peers. And they are also 20 times more likely to develop a mental health problem. So keeping that in mind, the Family Acceptance Project at the University of San Francisco found that if a young person went through conversion therapy, their high levels of depression was more than doubled to 48%. If a young person went through conversion therapy through their family members, their suicide rates went up to 33%. And if the family practiced conversion therapy in conjunction with a religious organization or a medical professional, their suicide rate of the young person went up to 63%. In New Zealand, we found, we got the Counting Ourselves report last year, which found that 17% of approximately 1,200 trans and non-binary people had experienced conversion therapy through a medical professional. That is, that a medical professional had tried to stop a trans and non-binary person from being trans or non-binary. These results are even more critical in the context of New Zealand, where we've got a diverse population with intersecting identities, and queer phobia or homophobia or transphobia tends to be now more amplified in communities that share the identity of ethnic minorities due to the colonial history that we share. So for example, I don't think of myself as just gay. I think of myself as a gay person who is also brown. I'm also Itoke, indigenous Fijian, Girmitia, descendants of the slaves, Indian slaves that were in Fiji. I'm also an immigrant to New Zealand. So when people acknowledge the intersectional identity of who I am, I fall to the bottom of the social hierarchy. However, there are more people who can fall even further. Keeping that in mind, keeping into mind that homophobia and racism are largely, before that I want to establish that intersecting identities of people do compound them collectively. So for non-white queer people, there's also the impact of racism and xenophobia that they have to deal with. So for ethnic minorities who share a queer identity, what happens is that racism and xenophobia and other factors exacerbate the rates of suicide and prevalence of developing a mental health problem. Keeping that into mind, homophobia and racism are largely colonial constructs. So we need to, as a solution, as a way moving forward, we need to really work on decolonizing New Zealand and the medical workforce if we're going to truly serve the intersections of the queer community. Queer people cannot continue to exist in systems that are anti-Indigenous because queerness itself is inherently and fundamentally Indigenous. To find a solution, I have co-founded the Conversion Therapy Action Group, and we're working towards a ban on conversion therapy and have gotten the support of the Green Party and the Labour Party. There's a lot of work to be done. However, in doing that work, what we need to keep into mind is that damage is being done while we're doing the work. Thank you. I'm happy to take any questions. Yep.
Thank you, Shaneel. That was really interesting. Thank you. It was brilliant. So that brings us to the Q&A session now. So thank you to all our panelists for your insightful comments and views. And thank you to everyone who submitted questions before the event. And I might see a couple in the chat as well, which we'll check in a second. So please keep them coming in as we'll attempt to answer as many as we can. Generally for Q&A, unless a question has been addressed to a particular panelist, I'll choose one of the panelists to answer first, but then I'll give the others a chance to also comment on the same question. So to our first question, and while Shaneel has still got the microphone as such, one has come in here to say, do the mental health issues differ for the superdiverse versus those for the general population? So Shaneel, would you mind just kicking us off on that one, please?
Oh, absolutely. There's no doubt there. We've seen the stats, and I think you'd be too naive to think that it doesn't, because if you've got intersecting identities, you've got diversity, there are multiple factors that are affecting your well-being. And I think that particularly because I share dual ancestry, so I've seen how the Itoke community works and I've seen how the Indian community works. And there is this idea of actually there is no such thing as mental health, or there is no such thing as mental health problems. So we're not even having that conversation in my family or in my wider community. And we've also seen that translated into mental health and suicide rates, for example, as Hinemoa pointed out that young Maori men have the highest youth suicide rate in the world, in developed countries, OECDs, and then we've got queer people who are 5 times more likely to commit suicide. So of course it differs, and it's exacerbated if you're sharing multiple intersecting identities.
Thank you, Shaneel. I'll open it up to the other panelists if they want to also comment or offer their point of view.
You hear me? Yeah. I just want to add what others already said. It's kind of the migration journey, and of course, it's quite a compared with my other mainstream mental health issues are more complex, and also people have to navigate through the complex system, especially how to get help will be quite challenging, especially language and culture barriers, but also consider there's a lot of challenge of the migrant journey as well. So those are the extra challenge for the people who are facing. And of course, discrimination and stigma are huge around those within the culture. And so that's why we're seeing the behavior that people are not seeking help when they need it to. So a lot of people, even when I was working in the DHBs, a lot of Asians are presenting at the crisis bottom of the cliff, and self-harm. So, and also the same, we have done the report last year, the Asian suicide is trending up as well. So we kind of, it's alarming that we have to do something before it gets worse. Thank you.
Thanks, Kelly.
Quick reminder, really. I think when we think of culture and we think of diversity, we think that culture is this like super explicit thing. But actually a lot of, if you grew up in New Zealand, a lot of the cultural norms are actually not explicit. And so if a migrant comes or a refugee, unless you explicitly tell them, this is the New Zealand culture and this is how you should ask for help. And this is, you know, like, it really presents issues when they are navigating and interacting with our health sector. So I think that's something to recognize, that there is unconscious bias, but there's also the fact that culture is not explicit in a lot of cases.
Yeah, if I could maybe follow on from that. I think one of the issues for me that this question raises is, how do we understand the underpinnings of mental illness? And we know that when you look at, for example, just to take the suicide statistics, you know, about half of the people that commit suicide have some contact with mental health services, but the other half don't. And in fact, you know, the underpinnings of mental distress may, in many instances, be best not understood as an illness. So we could invest in all sorts of services and improve access, but that still won't address this other huge group of people who are distressed but don't have an illness. And so improving access isn't going to reduce their rates of distress or reduce their rates of attempting suicide. I think what we're all saying in different ways is that there are structures within society that impose a whole range of oppressive, racist, discriminatory, sometimes subtle and covert, and sometimes incredibly overt mores, norms, ways of expecting people to behave, which are frankly make people sick. So, you know, for example, living in poverty, if you look at the refugee communities who come to New Zealand, if you look at the Indigenous communities in New Zealand, Pacific people, these groups are overrepresented in people living in the most abject poverty in this country. And we know that poverty makes people mentally unwell. So I think we're speaking about a whole range of things, specific illnesses, but also broader than that.
Thank you, Hinemoa. Okay, I'll go to the next question because I think we may struggle to get them all in tonight. Look, to some populations within ethnic communities, the concept of mental health is not familiar. With this in mind, what approach would be most effective in explaining the concept of mental health and why it's important to good health and well-being? And I'll ask Anil to kick us off for that one, please.
I think that question in more or less in big form has already been answered by Hinemoa's response. And I think it is how do you explain something? You know, a lot of people, when asked in the large studies as to why didn't they reach out to the mental health services, people would say, but I didn't know I was having a mental health issue because my wife had left me or whatever. I haven't seen my children for 6 months. I see that as a different thing, which is a general life stressor. So medical community has pathologized or has created terms, whether be it's depression or anxiety, or it could be step care modeling, whether be you're a mild end of the depression. How do I know that I'm mildly depressed or moderately depressed or acutely depressed so I can access appropriate services? So I think the language is a big barrier in itself as to how we design services, how we commission services. And if you are not working in healthcare, good luck to you to find which service is appropriate for you. So I 100% agree with what Hinemoa has said earlier on. But another thing is, many years ago, I was briefing the Associate Minister of Health responsible for mental health, Peter Dunn, in Wellington around a youth eMental health initiative called The Lowdown, which is Ministry of Health, and 19,000 people, 19,000 contacts via text messages were happening with the young people across New Zealand per month. Now, Minister was very highly surprised. He said, where were these people going before? And so I said to him, I was surprised with the question, but it was a good question. And so I said, perhaps nowhere. They were going nowhere because there was no mechanism, there was no channel for them to communicate that because one of the other key thing was, because there was a call center at the end of it, so every message was highly personalized. So it'll be like, dear David, you're going through a challenging time, your exams are around the corner, and your mom and dad are fighting all the time. Is there anything we can do for you? 1 in 3 users were responding back saying, oh, are you a real person? So we talk about technology is not the solution. Solution is the person behind it. The power of connection with another human being is, so this is what Aroha and Hinemoa talked about, the nature and the family, the earth. I 100% agree. But in the modern world we live in, how do we speak the consumer's language of the day in the way they understand it?
Thank you, Anil. I might go to the next question from here because I think one has been very well covered from the speakers. Thank you. This one comes to us. Could the panel recommend any wellbeing frameworks which are culturally appropriate and catered to diverse populations? I might hand that one to Kelly to kick off, please.
Thank you. I think the framework it's hard to kind of have one frame, but I think the goal of the culturally appropriate services that has to be like empower the community, and that's by all the diverse community that we recognize in New Zealand as well, to use more kind of holistic approach and using public health approach to destigmatize those like mental health, mental illness, and not labeling people, but empowering those community to have champions in the community to help people. Because another kind of anecdotal, like a lot of Asians or some of even cross culture, people are telling all their problems to their hairdressers. And so the hairdresser probably is kind of the helper in the community. So you got to empower, find those leaders in the community to kind of empower them to help people around and how to navigate through such a complex system. And also we have to have culturally appropriate services in place. So every door is the right door for all the people that come into any of the services as well. And if they're not even choosing to not meet the criteria of diagnosis of mental illness, then we should have a program in place in the community to help those prevention work as well. And same across with even suicide prevention, post-prevention, across all the communities. And of course, by all that means crossing different language and culture within their cultural contents as well. Thank you.
Thank you, Kelly. Any other panelists had anything else they'd like to add? So I'll just take a raised hand here from Sean. Sean, have you got a comment there? No, it's good. Okay, lovely. Let's go to the next question then. This one I'll direct at Angela. How do we ensure mental health and wellbeing approaches are integrated across sectors?
Yeah, so I think that, you know, I briefly touched on that. The idea really is to recognize that what Hinemoa was saying before is that, you know, mental health or well-being is very holistic, and that it's the wider determinants, like, do you have a job? Do you have a sense of meaning and purpose? You know, do you have a roof over your head? Those are, you know, Maslow's hierarchy of needs that are very basic. And so where that sits within the sector, obviously, is like MSD, for example. But then you look at sort of the fact that we talked about the missed opportunity. So for example, of those that have committed suicide, 50% of them were in employment. So, you know, what's the role of organizations to really be part of the solution? Because we spend majority of our time and our identity as part in our workplace, and vice versa for students in education. And so I think that when we look at mental health and sort of kind of putting it in a box that's neatly tied and said, oh, it's the Ministry of Health's problem and nobody else, you know, that we're just going to leave that responsibility to them. I think we missed the boat around understanding how do we truly build a society that's flourishing versus sort of taking an illness model where we're just trying to fix problems rather than say, like, you know, if you ask the question of like, hey, you know, do you feel like you are living your best life? Are you know, do you feel a sense of purpose of what you're doing? Do you feel connected? Everybody will be able to answer that question. But if you ask people, do you have a mental health problem? You immediately shut down majority of people. So I think when we take these wider, more positive frames, that becomes the starting point in which there is momentum in which for the whole cross-sector collaboration to occur. Yeah.
Thanks, Angela. Open up to the panelists. Okay, we'll move on to the next question. This one for Shaneel. The LGBT community tends to suffer more from isolation, even in normal times. Did you find that worsened during lockdown?
So I sit on the board of Rainbow Youth, and one of the things that come up during these times when we're forced into lockdown is that we find that a lot of young people find themselves in situations where they're in unsafe homes. So when we've got a young person going into lockdown in an unsafe home, how do you deal with that situation? We've already got, the Auckland Council already has released stats where they see that queer people, particularly trans youth, are disproportionately affected by homelessness. And it's already been pointed out that we need to take a holistic approach to mental health. So I want to just refer to the question that you asked earlier on models. So you've got the Whanawhale model for Pacific people, and that takes into consideration cultural, social, and familial, all factors. So in terms of social, we've got queer people who are affected disproportionately by unemployment and homelessness. And during COVID-19, you've got them forced into unsafe homes. So yes, during COVID-19, it did get worse, and we did see the impacts.
Thank you, Shaneel. A question here for those of us working in corporate workplaces, aka largely homogenous and based on Pakeha culture in all facets. Do you have any practical tips on working day to day and impacting cultures for change? And I'll get Hinemoa to kick us off on that one, please.
Oh, kia ora. This is a question close to my heart. I think prevention is key, and normalizing the emotional literacy, the conversations that occur. So the leadership in organizations need to have a 360 kind of analysis and an evolving analysis of the tone of their workplace, and have some meaningful ways to measure that, and using what you've heard from my colleagues, tap into the kind of language that is commonly used within your environment, to get a sense of maybe use like art scales and some fun around how people can touch base with each other and talk about their emotions. I've been involved in some discussions at Westpac Bank a couple of years ago with John Kerwin. They have their own health committee, and they highlight what we're calling mental health, mental illness, mental distress issues within the workplace. So they have invited speakers. So there's a whole range of things that you can do to normalise talking about feelings. I think is critical. That's preventative and protective. And then you've got to have some mechanisms to support people who are really, for whatever reason, struggling, and making that not a stigmatized process. So making that a very embracing, normalized process for people to seek help, and then for the organisation itself to have good partnerships with clinical providers in the wider community.
I might jump into that one too, and I think feeding onto Hinemoa's, this putting in mechanisms, I think that's where there is a real potential for technology to play a role in that. And so if you think about it from a perspective of, a lot of these solutions out there kind of already pigeonhole you into like how you need to answer these questions in a certain way, and so those frameworks in many sense already have a Western cultural lens put on it. And so one of the things that, for example, we do at Clearhead is that because our chatbot uses sort of natural language processing and machine learning, we actually just we are able to analyze the sentiment behind a person's statement. So we don't kind of pre-assume how to ask the question. We allow the person to, in their cultural context, ask the question in their own way, and then we pull out the sentiment behind that, and then the ability basically to then aggregate that data and then anonymize it and provide data insights to companies, for example. So those are the things that you can use technology and how technology is evolving to empower your organization through the use of data, but at the same time really inherently protecting the individual's privacy and data sovereignty from that perspective. So it's about that balance and how do you do it right, and how do you use smart technology to kind of really be able to solve problems. Yeah, cool.
Thanks, Angela, and thanks, Hinemoa. Look, I've got a number of other questions, but we really are drawing to time, so unfortunately we're going to have to end the session there. I'd like to once again thank all of the panelists for their valuable contribution, to Marina, Shivani, and the Superdiversity Institute for making this all happen, and to all of you for joining us tonight and for your questions and engagement. But before we go, I'd like to leave you with one challenge, please, and one request. My challenge for you to go forward and continue to be a champion in your community and personal professional networks. It's an incredibly important issue, and reach out for help as you do for those of us and others that can help you. My request is that you tell 3 people, the people about tonight's event, about the Superdiversity Institute and New Zealand Asian leaders, and invite them to join us at our next event on Thursday, the 23rd of July, which talks about the importance of diverse thinking on COVID-19 issues. So thank you, everybody. We better leave it there. Have a great evening. Thank you.
Oh, how she laughed. Right, leave.